the east, from Changi. You might be wondering why I agreed to give a talk in this area. And the reason is, actually, I grew up in Kim Tian Road. So this is home. And really, I think I share with many in the audience this concern for patients with giddiness problem, which sometimes we cannot make any head or tail out of. So, and even some of my colleagues in ENT practice will really find that dizzy patients are a real headache, real problem. So over the years, I have tried and simplify some of the diagnostic as well as therapeutic algorithms for these patients to make it simple, especially for a surgeon, we can only think so much. So we're going to share some of these conditions. So essentially, when we talk about dizzy patient, it is a problem with balance. And to maintain balance really is a multi-systemic function. Among them, of course, vestibular system is one of the most important. But it is just as important to look at the other systems. And I don't think we need to sort of emphasize the neurological system is very important. The musculoskeletal system is very important. And of course, any disturbances in the physiology, especially of the electrolyte or glucose, can make the patient dizzy. But today, we're not talking only about balance. We're talking about specifically dizziness of vestibular origin. And so, essentially, we need to know, or we need to ask ourselves, when a patient comes to us with dizziness, is it a central problem or is it a peripheral problem? And if we are able to say that it is a peripheral problem, then it's most of the time a vestibular problem. So how do we differentiate between a central or peripheral? There are 5 questions that we usually ask the patient. 3 steps in the examination and 3 modalities of treatment that we can institute in a patient. And these 11 things would help us not only differentiate between a central and a peripheral problem, but also to suss out what kind of peripheral problem so that we can treat this patient accordingly. What are the 5 questions? And essentially, the first question we need to ask is what type of dizziness? And we know dizziness may be vertiginous, non-vertiginous, and there are also many other types of description of dizziness. And I think some of you, I'm sure, will have experience with patients who try as they might, they just cannot describe how they feel. So sometimes I tell the patient, don't use the word dizzy, don't use the word giddy, but just describe how you actually feel during that episode. And it's still not easy. So the uncle will keep saying, hao gong gong, wei hao gong, but gong. So it is an important part of the history that we actually spend a lot of time on, trying to make them or help them describe exactly what we feel, because different things imply different diagnoses. The second question is whether there's associated hearing loss, and part of that will help us come to a diagnosis of dizziness. And also the trigger factors for dizziness will also help us in terms of the diagnosis. And really, the duration of dizziness is a very important clue for our diagnosis. And last but not least, associated symptoms in particular will be able to tell us whether it is central or peripheral. So let's go through some of these questions. And I think spinning, I think we all know, would then imply a vestibular cause of dizziness, but I put it as a caveat that vestibular dizziness may not always be vertiginous, and not all vertiginous giddiness are vestibular in origin. But by and large, for all our clinical practice, we can safely assume that if a patient suffers from vertigo or vertigo, depends on whether you want to use the American version, is a vestibular problem. So spinning, a vestibular problem. So patients will also tell you about sensation of falling, sensation of blacking out, and then walking to one side. And these are all sort of manifestation of potential vestibular problems. In particular, they will tell you when they have a vestibular problem that they feel like they are falling into the ground. Because there's a part of our vestibular system that subserve vertical movement. And some patients also tell you that they feel like they are moving horizontally. Again, that is a vestibular problem. So essentially, to summarize, any sensation or illusion of movement, it is likely to be vestibular in origin. Now, the triggers will also help us come to a diagnosis, and the common diagnoses for dizziness are listed here. So, BPPV have typical triggers, which we will talk about a bit later. And of course, other things like vestibular neuronitis will also have different triggers. By and large, the most important question after asking a patient whether it's spinning or not would be how long did the spinning last? And really, we have to ask them the most severe or the original episode. Because the duration of dizziness, of spinning, really help us pinpoint the diagnosis. And the table here illustrates what I mean. If the dizziness lasts for a few seconds, it's likely to be PPV. If it lasts from minutes to hours, it's a Meniere's disease. And patients who have vestibular neuronitis will tell you that this dizziness comes almost for a week. So, and each time it comes, it lasts for hours. Now, the next thing that we need to sort of put at the back of our mind is that once the patient has told us that it's spinning and how long the spinning lasts, then we must ask them for central signs. And I think we all would agree, peripheral dizziness will not have central signs. So if it's just a condition affecting the ear, you should not have neurological signs, for example. And this very illustrates this principle very well. So these three common so-called central dizziness conditions manifest in the same way as patients with peripheral dizziness, right? They have nystagmus, they have spinning, they have nausea and vomiting. But on top of that, they also have central signs. So the moment a patient tells you, I have spinning, nausea, vomiting, and I also have, for example, weakness in one arm, or numbness in my face, or I can't see very well, that is not a pure peripheral problem. So it is an important concept for us to bear in mind. Peripheral dizziness does not have central signs. So the next thing we want to ask the patient, of course, is associated symptoms. And these will, like I said, help us to exclude the central causes, for example, neurological causes of dizziness, cardiac causes, and an often neglected area is autotoxic medication, which is increasingly becoming a problem, especially in light of these recent medical legal things. Asians, unfortunately, have increased susceptibility to aminoglycoside. And we have quite a few patients who become dizzy after prolonged treatment with gentamicin. And of course, we have our fair share of patients who have psychiatric conditions who present to us continuously for dizziness. So, but of course, that will not be our first diagnosis in these patients. So once we are done with history, and we will talk about history again later on, we then go on to physical examination, and really the physical examination will serve to confirm or exclude our diagnosis from the history. So the three areas that we examine are the ears, the eyes, and of course the neurological system. In the ears, we look at whether there's infection, there's a perforated eardrum, or other things. That is straightforward. In the eyes, there are special things to look out for, and in particular, this thing called the nystagmus. And nystagmus really is a sort of a classic symptom of patients with dizziness. So the nystagmus of a peripheral condition is as such. These are the features that would suggest that this is a peripheral problem. So if you look at this video, a patient with nystagmus of peripheral origin will have jumpy eyes. But if you look at the eyes, there's a slow phase and there's a fast phase, right? But if you just look at him, you will notice that the eyes is actually jerking to the right side. He's right. So this is called nystagmus. And what you notice is that the jerking motion is equal in both eyes. So it cannot be faster in one eye and slower in the other. And it does not change direction. Whether the patient is looking right, looking left, he will always be beating in one direction, to his right in this case. And of course, a peripheral problem never have vertical nystagmus. So if you see somebody's eyes jumping up like that, then it is not a peripheral problem. So you need to bear the possibility that it's a central cause in mind. So nystagmus is the first thing we want to look for in a patient with dizziness, especially when the patient presents acutely. Usually you can see some kind of nystagmus. So I illustrate here something that is not peripheral, and you will see clearly why. And the reason is because it's only happening in one eye, and it changes direction. So when she looks right, it beats right. When she looks left, it beats left. And it only happens in one eye. So it defies all the criteria for peripheral nystagmus, and therefore it is not peripheral. So this lady was a lady we saw a few years back, and she has systemic sclerosis, which is not a common condition, of course, in Asians, but suffice to say that once you see such weird nystagmus, it is not peripheral. Then, of course, we have to look for central causes. The next thing we want to look for, besides nystagmus, is what we call a head thrust. This is a simple test to do in a clinic, but it might take some time to conceptualize. But essentially what we do for a patient is, this lady has a left vestibular problem, and when we turn her head quickly to the left, she's supposed to keep looking at you, but you notice that her eyeball actually shifted. So play it again, look closely, see the eyeball have to shift back, he loses its focus, right? Whereas when you turn it to the right, he keeps looking at you. So that's a head thrust test. And it is a very quick kind of screen for the connection between the eye and the ear. Because this tests the so-called vestibular ocular reflex. And when the vestibular ocular reflex is lost, we can safely say that the vestibular system is at fault. Of course, provided the eye movements are normal. So, what are the red flags that we look for in examination? We have already talked about abnormal nystagmus, which is either direction changing or only happen in one eye. And of course, when there is a positive head thrust, without a positive head thrust, the patients keep complaining of vertigo, then it's not peripheral. And all these are the other things we talked about. Peripheral vestibular disorders does not have central signs. So once they have central sign, it's a red flag. So once we have got this diagnosis confirmed on examination, we can go about treating, and the treatment, to my mind, can be categorized into these three main options: abort the symptoms, maintain the condition, as well as do rehabilitation. So how do we abort? Essentially, we give, I think we all know, what we call a vestibular sedative or suppressant, which is stametil and sturgeon, which is quite common in our practice. And once the patient feels better, most of the time we recommend suppressants for not more than 5 days. Once they feel better, we should start getting them onto maintenance therapy. And one of the best medication, and of course today we're talking about beta-histine, and it is not 16 milligrams anymore, it's 24 milligrams. Just a disclaimer, I do not have any shares in Abbott, but I find this medicine extremely useful for my own practice. So once the patient's symptoms are suppressed with the initial medication, we should get them on this maintenance therapy as well as vestibular exercise. Now, there is a handout in your file that would be useful, I think, to recommend to your patients for simple exercises so that they can get quickly rehabilitated. And this is based on the principle that vestibular conditions very quickly resolve when patients go on this rehabilitation. Occasionally, they may evolve to another condition, but with these exercises, they usually recover quite fast. And this is the common sort of natural history of vestibular dysfunction. So A, this line represented by A is what usually happens, probably 60-70% of the time. So with time, the patient recovers the baseline balance function. And of course, especially in some conditions, they do go through bad days. And this really depicts the natural history of giddiness in the elderly population. So they never really quite get back to baseline, and in fact, they go through all these very bad days. And this is the part where they really need help to get their vestibular rehabilitation going. So one of the simplest exercise to do, which you can find in the handout, is doing what we call a gaze stabilization exercise, and you can do it right here, right now. Put your thumb on an outstretched hand and look at your thumb and move your head from side to side. People with a vestibular problem will never be able to do that. They start feeling dizzy. After 2 seconds, they want to vomit. But you tell them to keep doing it as much as the body allows, and they will find that the duration will get longer and longer. And after a while, once they feel much better, they start to doing it when they're walking forward and then backwards. Okay, and this is a very good rehabilitation exercise for patients with vestibular problems. Very occasionally, we do need to do some investigations, and some of the investigations will include things like video nystagmography and calorics tests to see how much balance function the patient have lost, and of course imaging, as we've mentioned, especially we suspect a central problem. But this last part of my sharing would be on the 3 most common conditions that I see in clinical practice. And really the number one, as we all know, is BPPV. And the second one is what we call vestibular neuronitis or neuritis. And one of its associated variant called labyrinthitis. And the third is Meniere's disease. And we'll go through each of these in a bit of detail. The first one is BPPV, and I think we are all familiar. This is the most common cause of giddiness, especially in the middle-aged. And unfortunately, in the female population. And nobody really knows what causes BPPV, so most of them are idiopathic. But recently, in probably the last 5 years or so, I've noticed a lot of patients who come to me with BPPV who are ladies and who are doing yoga. And I think, I don't want to blame yoga, but I think some of the yoga stands might be putting their head in abnormal positions. And so the otoconia from the inner ear has been dislodged. So that's what we found recently. Yeah? But really the pathognomonic thing about BPPV is that they have very specific triggers. So they will tell you that when they lie down to bed at night, as they lie back, they have this momentarily spinning sensation. Or in the morning, they get up from the bed, they have that spinning, or looking up to reach for something on a high shelf, they have that spinning. And of course, the ladies will say when they go to the salon, lie back, they get their hair washed, they spin. So these are very specific triggers, and spinning lasts for seconds and maximum a few minutes, and then it's gone. So that's a very clear sort of a indication that it is BPPV. Now, the classic diagnostic examination for BPPV is Dixor pipe, and of course, if your GP room allows you, you can do a Dixor pipe maneuver to diagnose BPPV. And the picture here, which will be provided to you later on, shows how you do a Dixor pipe maneuver to test the right ear. So to test the right ear, you first turn the patient's head to the right 45 degrees. To test the left ear, you turn the head to the left 45 degrees. And accordingly, you put the patient back and ensure that you drop the head slightly below horizontal. And this really is to stimulate the posterior semicircular canal of the inner ear. And if a patient has BPPV, they will have very typical signs and symptoms. And this is what you will see if you look at the ISO. We tell the patients keep their eyes open. And what you see is the typical nystagmus of BPPV, which satisfy all the criteria for peripheral nystagmus. Same and equal in both eyes, but also some rotatory component. And you will notice that it builds up to a crescendo and then it slows down. And of course, if it's the right ear, there's a problem. It will beat towards the right, which sometimes we call geotropic. And of course, on sitting up, occasionally it will reverse in direction. So that will clinch you the diagnosis of BPPV. And how do you treat? You treat it by doing the classic Apley's maneuver or the canal leaf repositioning maneuver. As we know, 90% of BPPV is caused by this rogue otoconia in the posterior semicircular canal, which is little dots here that you can see in the posterior semicircular canal. So they have been dislodged from this bulbous part of the inner ear called the vestibule. What the Abbott maneuver does is that you try to shift all this otoconia back into the vestibule. And you just need a very quick sort of a maneuver to try and position them back. So we start by a Dixor pipe. So the patient will be spinning, the eyes will be jumping. If you are lucky, they will not be scratching you. So once the nystagmus is over, you just turn their head to the opposite direction. And that is position 2. And you wait for a while. Sometimes they will have spinning again. You turn the patient some more until they look at the floor. So this picture will then illustrate, it follows where the otoconia moves, and finally you get them to sit up, you drop back into the vestibule. So it's a very brilliant kind of maneuver. It was discovered by Dr. Apley. He's from Portland, Oregon, in the United States. So it's a very efficacious maneuver. A patient gets well very quickly. And of course, it is very easy to do even in general practice. Time allows. And of course, we have rarely patients who, despite treatment, do not respond. Then you will need surgery. Essentially, what we do is, if there's autoconia moving inside, we prevent them from moving. And that's what we do, canal plugging. So we just obliterate the posterior canal, and patients do not have symptoms anymore. The next condition is vestibular neuronitis. The age group is really similar to BPPV in the middle age. And again, very classical signs and symptoms. So vestibular neuronitis come on suddenly. And a lot of patients say they suddenly are woken up in the middle of the night by this spinning, and they have to run to the toilet, start throwing up. And this spinning sensation lasts pretty long, for minutes to hours. And nobody really knows what causes vestibular neuronitis. Some think there is a viral illness, but the studies have shown that less than 50% of patients have a preceding viral illness. So the jury is still out on the real underlying cause. Important thing to know about vestibular neuronitis is that 20% undergo incomplete resolution. And this is the group that will come to you with no spinning. And that's why we put a caveat just now that not all peripheral vestibular problems have spinning. But if you ask them about the first episode, they will tell you that it was spinning. So the treatment is the same, acute phase, vestibular sedatives, and increasingly there is evidence that giving some steroids in the acute phase will help patients get well faster. But the maintenance phase is beta-histine and vestibular rehab, as we have already mentioned. So this is my experience too. In the acute phase of vestibular neuronitis, we do give vestibular suppressant and start at the same time beta-histine. And after 5 days, we stop whatever suppressant, it may be cinnarizine, it may be stamatil, and we continue with the beta-histine. And this is really hot off the press. This is this year's publication. There have been many studies that show that a short course of steroids during the acute phase of vestibular neuronitis will allow the patient to recover faster. So the last thing we want to talk about is Meniere's disease. And Meniere's disease, surprisingly, is more common than we think it is. But fortunately, in Asian, Meniere's disease is easier to treat than in a Caucasian. And so we always talk about the triad of symptoms, which is episodic vertigo, fluctuating hearing loss, and tinnitus. But really, there's a number 4, which patients often complain of, is the sensation of ear fullness. So if you ask them, they will tell you the ears feel blocked, and then suddenly there's a ringing sound, followed very quickly by this spinning sensation, and they start throwing up and things like that, and they notice that they have hearing drops. So for us, it's very good if you are able to pick up the fluctuation in hearing loss. So if this patient, just to illustrate, the left side is the culprit, and when they first came to us, there's a low frequency sensory neural hearing loss typical of Meniere's disease. And as the patient gets better, the hearing actually improves. So a very classic fluctuation in hearing of Meniere's disease. And of course, if hearing can be lost, if the patient is not treated, what we call persistently active Meniere's disease, because every time an episode of Meniere's disease happens, it is an inflammation. Any episode of inflammation of the inner ear can result in permanent hearing loss. And we do have patients who have who lose their hearing if they delay treatment. Essentially, Meniere's disease, the treatment, we reassure the patient that even though it keeps happening, it's not something serious, and we need to institute the accord maintain and rehabilitation regime. Now, there are many patients who will respond to beta-histine as primary treatment for Meniere's disease, but we do have those who are refractory to treatment. And so the next step in the treatment ladder in this day and age is intratympanic gentamicin injection. So what we do is we take gentamicin and inject it through the eardrum into the middle ear, let it sit for a while, and the patient lie down for 20 minutes, and it's supposed to diffuse through the round window membrane into the inner ear, and the aim is for it to knock out those hair cells that are causing this episodic inflammation. And so the vestibular function on that side drops, and it is, I explained to the patient, it's like flying a plane on an engine that is sputtering. So on and off, it sputters, it goes off course. You might as well just shut down the engine and fly on one engine straight. So essentially that is the principle of intratympanic gentamicin. There are many ways you can give. Essentially what we do in CME is that we give them 5 days of injection of gentamicin. Control rate for vertigo is extremely good. It's in the region of the 90%. And unfortunately, of course, there's a little trade-off because not only is gentamicin vestibulotoxic, it's also cochleotoxic. So some patients can have hearing loss. And it's important to tell them that they have to achieve a balance between the two. And of course, like everything else, when they do not respond to medicine, we operate on them. And the numbers to require surgery is very low. So, after talking about these 3 most important conditions, or rather most common condition, essentially there is a Cochrane review that looks at beta-histine for vertigo from all causes. And the author's conclusion is that although the current available studies are not fantastic, they are not of a very rigorous standard, there seems to be a trend towards the use of beta-histine being very useful in patients with vertigo of any cause. So, and there's also studies that are increasingly being published about peripheral vertigo, again from all causes. It's very hard to break them down into specific causes, but essentially, if you summarize the picture, essentially you can include that beta-histine, any patient with peripheral problem that's causing them dizziness, you can start beta-histine. And I suppose this is a sort of a suggestion of when other causes need to be ruled out. And of course, I think the central causes we really mentioned. You think a patient has central cause, it is I suppose timely to send it to a neurologist. And of course, after treatment, the patient continues to have vertigo or dizziness, and the diagnosis is not clear. I suppose the referral will be important. And also in those patients who we are sure of the diagnosis but they need treatment, for example, a patient with Meniere's disease, you know they have been treating this patient for a long time, continue to have episodic vertigo, we need definitive treatment in the form of intratympanic gentamicin. Refer these patients to an ENT. And of course, patients who require investigation and also. So to summarize, in this short session, we mentioned 5 questions that we can ask our patients to diagnose peripheral versus central dizziness, and also to try and suss out what is the cause of the peripheral dizziness. 3 things to look out for in the examination, and finally the 3 modality of treatment. And I just put together a table again, this deck of slides will be available to you. Just to summarize some of the major features of the three most common conditions in clinical practice. So with that, I thank you very much for your attention.